Hi, my name's David Evans from Bangor University, and I've had the pleasure of working with a group of practicing dental staff to develop this draft, Perio Pathway. We were asked to develop a straightforward overview of 12 months of care for patients and their perio needs. The purpose of this video is to provide you with an introduction, an overview, and examples of how this draft Perio Pathway would work. The group involved in developing it includes Rosie Newport, a dental therapist, Laura Parvu, a practice manager, Lowry Jones, a community dentist, Sam Johnson, an associate dentist, and Lawrence Best, a practice principal. Our ask of you is to consider the pathway and discuss the questions we pose and identify comments, critique, and questions you may have. There's no perfect pathway, and this process seeks the views of staff working across the dental system. We will use the feedback to discuss with stakeholders across dentistry before sharing a first version for sharing more widely. On the screen now are some of the principles that drove our development of the pathway. I'm not going to go through them all, but what I'd like to do is just point out a couple of key aspects. Now, the first one is the pathway starts with ACORN assessment, and it starts once that's been undertaken. And of course, the focus of ACORN is on identifying and managing risks, and then following that up with prevention. Patient engagement is also key and determines the progress through the pathway. But again, we'd welcome your thoughts on these principles. So before we look at the detail of the pathway, in its briefest view, the 12-month view of the patient pathway looks like this on the screen. There are 3 steps to it. The first one is establishing the diagnosis and the annual plan for that patient. The second ensures that the patient is now in control of their treatment and engaged with the process. And the third step is the complex treatment and improvement is undertaken with the patient over the 12-month period. What I'm going to do is hand over to colleagues who will talk you through the process in more detail, and each will start from the point of view of the ACORN assessment having been completed, and will illustrate the pathway for each risk category of patient.
Green patient, 12 months recall. Gwen is a 27-year-old teacher with a very good oral hygiene. She comes to see the dentist for her 12 months checkup. There are no risk factors in her medical history. She is a non-smoker. She only drinks socially when she's going out with her friends. She never had dental treatment. She is only attending the surgery for her 12 months checkup appointments. After completing the ACORN form with all green and BPE 000010, the dentist reinforces the oral health advice and discusses other ways to prevent plaque, along with a referral to the oral health educator. The dentist is then asking Gwen to come back in 12 months' time for her next checkup and book to see the oral health educator. The patient is willing to engage and actively participate, keeping up with her appointments in order to improve the well-being of her oral health.
Next, we're talking about Amber for someone without periodontitis, but who is at risk of developing periodontal disease. We're going to look at Gareth's case. He is a 38-year-old with a busy family life, a couple of children, and a demanding, stressful job where he works shifts. He doesn't always have the time to brush his teeth twice a day. He's sometimes just too tired, and he is partial to smoking, especially when he's at the pub having a couple of pints with his mates. His clinical findings would be a BPE of 2, 1, 2 across the top and 1, 2, 1 across the lowers, with generalised bleeding on probing. After the ACORN assessment, we would want to take further diagnostic examinations to ensure that Gareth doesn't actually have radiographic evidence of bone loss and to confirm our diagnosis of no perio. We would need to record a diagnosis of generalised gingivitis and acknowledge his risk level for developing periodontal disease in the future. We would then explain these findings to Gareth, including his risk level. In the past, this is the point where most of us would have likely spent a couple of minutes removing any calculus before sending Gareth on his way and reviewing him in 6 months. And this is where the pathway changes things. If Gareth had said, "Look, I'm too busy and it might never happen," he would exit the pathway without treatment and his periodontal condition would be reassessed at his next annual ACORN. If, however, Gareth said, "Oh no, what can I do about it?" he would be given access to the second step for Amber within about a month. At that second step, there might be removal of supra and subgingival calculus if it was necessary to facilitate prevention, and he would be given thorough and structured advice on what he could do to manage his disease risk and the areas of active gingivitis. For Gareth, that would be smoking cessation advice, detailed instructions and demonstration of how to use appropriate interdental cleaning aids, as well as his toothbrush. It would also be wise to remind him of the risks of not using those tools in the long term. His periodontal pathway would then terminate and he would be reviewed at his next annual ACORN.
Hello, I'm Rosie and I'm a dental therapist. I work across multiple sites alongside dentists, dental hygienists and dental nurses with additional qualifications. To represent an example of a patient's annual journey when presenting with code 3 BPE in the posterior sextents, I am going to talk about Gina. Gina attends the practice as a new patient. She is 37 years old and has no known medical conditions. She describes herself as a social smoker. At this initial appointment, Gina is informed of a diagnosis of localised periodontitis, stage 1, grade A, currently unstable, with a risk factor identified as smoking. The dentist performs an initial modified bleeding score of 63%. She is using a manual toothbrush and does not currently use anything to clean interproximally. The dentist takes horizontal bite wings at this appointment, which show bone levels and stage 1 loss. She receives tailored oral hygiene advice and is recommended to return in 1 week's time to see the dental therapist. At this appointment, the dental therapist records a modified bleeding score of 46%, noting some improvement and praises for this. They then reinforce the oral hygiene advice, the toothbrushing advice, the interdental cleaning advice, and also the smoking cessation advice. They also perform a gross interproximal scale to facilitate the patient's oral hygiene at home. The patient is then invited to attend in 12 weeks' time with the oral health education nurse. At this appointment, the patient has purchased an electric toothbrush, is now using interproximal aids every day, and has quit smoking completely. A modified plaque score of 17% is recorded, and the patient is praised for this improvement and proof of engagement. The patient is then recommended to return in 1 week with the dental therapist for an appointment to record a detailed pocket chart and to perform root surface debridement where necessary. Following a further 12 weeks, the patient then returns a final time in this year for a comparative chart. The patient's diagnosis at this appointment is localised periodontitis, stage 1, grade A, currently stable, with pocketing less than or equal to 4mm and bleeding on probing less than 10%, with no bleeding on probing at any 4mm sites. The patient's next appointment will be their annual ACORN assessment with the dentist. To discuss a non-engaging patient attending the dental practice with code 3 BP recorded during initial screening, we will again discuss Gina. Gina would follow through the same diagnosis route, would receive a modified bleeding score and be given tailored oral hygiene advice, smoking cessation advice, and offered an appointment in 1 week's time with the dental therapist. The dental therapist would again use this appointment to record a modified bleeding score, to reinforce oral hygiene advice that was given, to ensure the patient is happy with the use of any aids that have been recommended and allow time for the patient to practice with these aids as needed. They would then perform a gross scale to facilitate improved home care and oral hygiene. Gina would then again be offered an appointment with the oral health education nurse, whereby it is recorded that she has made no improvement with her oral hygiene and is not demonstrating any engagement with her treatment. She is therefore deemed to be a non-engaging patient and is informed that until a level of engagement is shown, she cannot progress forward to non-surgical periodontal therapy. She will then be seen again at her annual ACORN assessment appointment with the dentist, where her engagement will be reassessed. It is important that at each contact with Gina, she is fully informed of her diagnosis and the responsibility she has in her own treatment. This should be clearly recorded in her clinical notes and continuing informed consent gained.
Hello, I'm Sam Johnson and I am an associate dentist here at Rabban Road Dental Practice, and I am going to explain to you our red patients. So we'll start with the first patient, who is the red non-engagement. So these are people who have active periodontal disease but have an indication that they don't want to go ahead with treatment, which is perfectly fine because everybody needs to make their own decisions about their own health. And it's actually probably the most important thing about this whole Perio pathway is the patient's engagement. So the non-engaging patient, there's an exam, and then it's picked up that that person has had or has periodontal disease, and there's a provisional diagnosis made. You tell the patient about the gum condition, and you ask them if they're prepared to engage. Engagement means brushing twice a day, flossing every single day, and basically just doing everything that needs to be done to clean their teeth correctly. Some people may put their hand on their heart and say, you know what, I can't commit to that type of treatment. That's absolutely fine. It's written down in the notes, and then the patient is seen in 12 months. I think it'll also be interesting if we offered the patient some basic OHI, either with you, a therapist, or a dental nurse. So the second type of patient is a little bit different to the non-engaging. They're the engaging. These are the people that want to actively seek out treatment for their condition. So similar to the non-engaging, they have an exam and they have a provisional diagnosis made up. They are alert to the fact that they have gum disease, and they ask if they would like to treat this disease, and they say yes. So special tests are carried out, such as x-rays, bleeding scores, and the pocketing is recorded, and this creates a baseline. We know where the patient is at this point with regard to their disease. A working diagnosis is then carried out based on these special tests, and the patient has to go through a mandatory OHI session. All this can be done in one session, or all this can be done in separate sessions. It depends on the clinician and the setup of the surgery. A scale and polish is also sometimes required, but not always. It all really depends on how appropriate it is. The patient is then left to go away for 3 months to carry out their own cleaning, and once they come back in 3 months, we check their engagement, and this is done a few ways. This is done by checking the baseline again to see if the bleeding has improved and all the plaque has improved. We also check the patient's attitude to see if they remember from last time. If the patient is engaging, then the OHI is reinforced based on the special tests, because sometimes we can see if they're missing in areas, and then a deep scale is carried out. If the patient isn't engaging at this point, it's a conversation to have between the clinician and the patient to see if it's appropriate for the patient to carry on with their treatment. If it isn't appropriate, they are recycled next on to the next exam or in 12 months.
Well, thank you very much, Laura, Lowry, Rosie and Sam, for giving us those overview of the pathway. Before I hand over to the facilitators, there are a number of questions which we've come up with during our working up of the pathway, and we'd like to open with those to start with discussions in your individual groups. As a group, we've identified a number of questions that we would particularly appreciate your input and guidance on. You can find them on the screen now, but we'll also make them available to support your consultation session. We will really value and appreciate your feedback on the Perio Pathway, and it will help the development and subsequent rollout of the pathway across Wales.